Good morning, good afternoon, and welcome everyone to today's webinar. What can we do when prognosis is poor? The patient family's hope is for a miracle and the treatment team feels stuck. I'm Andrew Andresco, Project Coordinator for Transforming Chaplaincy, and we are delighted you could all join us. The reception to this webinar has been amazing. We had over 660 registrants, so we are thrilled that those of you who could join us can. Those of you who can't will automatically receive a link to the recording, whether you attended or not. So fear not. Some housekeeping instructions off the top. You are listening in using your computer speaker system by default and are muted. Should you have any technical questions regarding your audio or visual, please type those into the chat box located in the platform's dashboard. You will have the opportunity to submit questions for our presenters by typing your questions into the questions pane of that same control panel. You may send in your questions at any time during the presentation. We will collect these and we'll include them during the Q&A session that we're going to be having at the end of today's presentation. With that, I'd like to introduce Paul Gauchut, convener of Transforming Chaplaincy's Hospice and Palliative Care Spiritual Care Network. He's a research staff chaplain with Fairview Health. Paul?
Thank you, Andy. I appreciate the partnership and all the work that you do that goes into creating these moments that are here for us. And a huge welcome to our presenters and our respondent today. And I will offer some introductions here in just a moment. But before we do that, I want to say thanks to all of you who are already a part of the Hospice Palliative Spiritual Care Research Network. It is not just for chaplains. Even though we come under the banner of Transforming Chaplaincy, it's a closed network, meaning we don't advertise. So I promise that unlike your Twitter or your Insta, you won't get any sort of embellishing ads for joining some sort of this or that, but it's you'll just get emails from me that try to invite you to the latest peer-reviewed evidence. Next slide, Andy, please. So it's created to have a place for you to foster some connection so we can inform one another, explore, and to coordinate. And to that end, next slide, Andy, please. We'd love to have you join us. Just go on the QR code. I'd love to say that we have operators standing by. That would be me. So if you do get into this, you'll get a little thing that says request to join. I'll go into my network and I will have you join us there. It's free. Again, you won't receive any advertisements. I try never to send more than one email a day about articles that are coming out. Just try to stay informed. There's almost 900 of us, so we'd love to have you just push us over the edge on that. And as you can tell, I'm kind of a baseball fan, and we are getting near the end of the season. And it's we're sliding into it. So I'm a Minnesota Twins person. I just have to say it's kind of fun because there's some Boston people that are here, including Andy and Sarah. And my Twins played the Bo Sox last night. They got the W, so I'm pretty happy about that. And we'll go to the next slide, please. Not in Boston, but close to it. Our first presenter. I want to say about all these presenters, they have all in one way or another contributed to the peer-reviewed learnings for us in this field. So last spring or early kind of winter, I got to hear Dr. Rabbi Leah Tenenbaum present for the American Academy of Hospice and Palliative Medicine. And Leah, you know this, you knocked it out of the park in my opinion. I'm so glad that you're going to be able to share some of that content with us. Leah is the chaplain for the adult inpatient palliative care team at Yale New Haven Hospital, where she also serves on the bioethics committee. She's an ordained rabbi, pursued her rabbinic studies at Hebrew Union College, Jewish Institute of Religion, where she obtained both a Master of Hebrew Letters and a Doctor of Ministry. Leah recently received an advanced board certification in palliative care and hospice. Leah has presented both locally and nationally on the role of faith, spirituality, and advanced care planning. She is passionate about bioethics, spirituality, over the trajectory of serious illness, and listening to people's stories. And friends, staying with the baseball fan kind of thing, I'm a big fan of walk-up songs and how they have that distinctive sense of kind of who we are. And Leah's walk-up song is Katie Lang's, if you click the next thing there, Andy, hopefully it comes up, is Katie Lang's version of Hallelujah. So thank you, Leah, for being here among us. Presenting after Leah will be Reverend Rhonda Cooper. She's the chaplain at the Kimmel Cancer Center at Johns Hopkins in Baltimore, Maryland. Rhonda is a United Methodist clergywoman. She served in the local church until 24 years ago when she entered as a CP resident at Wake Forest Medical Center in Winston-Salem in 1998-99. Were you 12, Rhonda, at that time? She's also served as a healthcare chaplain ever since. She is most indebted to her team member at Johns Hopkins and her continued growth in her clinical skills. She's published in several journals, including a case study in the Journal of Healthcare Chaplaincy in 2011, as part of an effort led by the Director of Transforming Chaplaincy, Dr. George Fichette, and an article on palliative chaplaincy in the Journal of Pain and Symptom Management in 2017, in collaboration with oncology colleagues. She also wrote, and my big reason why I'm happy you're here, Rhonda, the Amen article on responding to patients' caregivers who hope for a miracle in spite of a grave diagnosis. And that was published in the Journal of Oncology Practice in 2014 for those whose fingertips are on pubmed.gov as we speak. Thank you, Rhonda, for being here. And Rhonda's song, this will come as maybe as a huge surprise to many of you. Drum roll. Next slide, or next little click there, Andy. Help me. Rhonda from the Beach Boys. All right, and third for us here today is Dr. Sarah Byrne-Martelli. Sarah is the inpatient chaplain at the Massachusetts General Hospital Division of Palliative Care and Geriatric Medicine. She has served as a palliative care and hospice chaplain since 2002. She is the inpatient chaplain for the Massachusetts General Hospital Division. I'm reading your title a second time. And she's on the faculty of the Harvard Medical School Center for Palliative Care. She holds a Doctor of Ministry from St. Vladimir's Orthodox Theological Seminary and a Master of Divinity from Harvard Divinity School. And not on this intro, but friends, if you also have your fingertips on Amazon or your favorite bookseller, you can find Sarah's most recent book on grief. So you can drop and find it there. Before you even read Sarah's or have it come up your walk-up song selection, I just gotta say, someday I hope you can sing that. And I would love to hear that funk band thing that you did where you presented Rocksteady by Aretha Franklin. Soul. You are definitely a soul sister among us, Sarah. So our respondent today, last but not least, of course, is Dr. Eric Widera. Eric is professor of clinical medicine in the Division of Geriatrics at the University of California at San Francisco, and is the director of hospice and palliative care at the San Francisco VA Medical Center. Dr. Widera is a clinical educator in the Division of Geriatrics. His main goal is to improve the care provided to elderly patients with severe chronic and/or terminal conditions through program development and educational innovations. He accomplishes this through various leadership roles, including being the director of hospice and palliative care service at the San Francisco VA. He is a past member of the board of directors of the American Academy of Hospice and Palliative Medicine, and is a co-founder of GeriPal and KRLC, looks really familiar to you, in a geriatrics palliative care blog and podcast, as well as leader with ePrognosis, an online set of prognostic calculators for the elderly. And it's perhaps your walk-up song that I like best, Eric. And without a drum roll, Andy, click it. Sure, 6-star show. I had to download it, buy it, but I loved it. So thanks so much, Eric. To all of you presenters, thank you so much. Leah, if you would, will you lead us off with your presentation?
Thank you. Thank you, Paul. Good morning. Actually, good afternoon, depending on where you are. I'll be starting off us off today with a focus on the language of miracle references, but I'd like to begin with the broader context of epistemology. Oxford Dictionary defines epistemology as the theory of knowledge, especially with regard to its methods, validity, and scope. It is the investigation of what distinguishes justified belief from opinion. It is what we know, how we know it, and why we believe it to be true. This diagram captures 4 different epistemological perspectives. These 4 perspectives are not exclusive, but they're quite common based on my work with palliative care patients and their families. If we start in the upper right-hand quadrant, we find the scientific perspective, which believes that the empirical method is the basis of knowledge. This is an evidence-based approach. It is rational, meaning based on facts and reason, and it has an internal locus, meaning the individual is responsible for creating or understanding outcomes. Next, we move to the chance perspective, just to the right. This perspective believes that the occurrence and development of events happens in the absence of any obvious design. It is based on probability. It is rational and has an external locus, namely the individual is not responsible for creating or understanding outcomes. If we go to the lower right quadrant, we find the karma perspective. This perspective believes that what happens to a person happens because they caused it with their actions. It is an action-based approach. It is non-rational, meaning it is based on one's feelings or emotions, and it has an internal locus. Finally, we come to the divine perspective. This perspective believes that God has a plan that incorporates all. It is faith-based, non-rational, with a clear external locus. You might have also noticed the arrows in the middle. These 4 quadrants represent people's core beliefs, which tend to be fixed. However, the arrows indicate that there can be some fluidity over a lifetime, especially as the result of significant life events, such as a serious illness. Next, please. Next slide, thank you. Based on these 4 perspectives, one might think about miracles very differently. It is good to be aware of what your patient or family, as well as what you yourself, might be thinking in regards to 1, what is the meaning of miracle? And 2, how do you relate to this concept? So for example, if a person has a scientific perspective, the meaning of miracle is that it's an irrational concept, and how they relate to it is with a sense of disconnect. If a person has a chance perspective, the meaning of miracle is, well, it's something that could happen. And how do they relate to it? It's irrelevant. After all, anything could happen. If you have a karmic perspective, the concept of miracle is based on one's merit, and it is a relevant topic. And if you have the perspective of a divine plan, then a miracle is anticipated, and it is a foundational concept. Understanding miracles through these different lenses gives us the opportunity to check our assumptions, examine our biases, and grow in our learning. Next slide, please. Let's take a closer look at assessing miracle references. This chart focuses on miracle language as a predictor of conflict within a medical setting. Along the y-axis is style, and along the x-axis is substance. There are 3 shaded areas addressing the underlying basis for the use of this language. In the yellow shaded area, miracle references are primarily generic. They are colloquial, mostly stylistic and non-substantive expressions. In the blue shaded area, the miracle references are usually coming from a deeper place and could be expressing specific psychosocial needs, such as feelings of anxiety or anticipatory grief. Perhaps there may be financial concerns, family conflict, or guardianship issues. There is more substance and specificity to these expressions. They are not just generic. In the green shaded area, we find a theological basis for the use of miracle language. This is a substantive use of miracle language. It is specific and based on a person's understanding of how God works. Take a look at some of the quotes from actual cases that demonstrate this continuum. You may have heard similar references in your own practice. Notice the arrow. It ascends, denoting the increased potential for conflict as we assess the language to be less stylistic and more substantive, and the basis for the use of the term miracle to be less generic and more theological. Next slide, please. For people with serious illnesses, the literature shows that miracle belief is not an outlier position. Rather, it is a significant portion of this population. So let's take a deeper dive into building that bridge of communication as we follow a patient along his trajectory of a serious illness. Observe, what is the clinician saying? What is the faith-based person understanding? Let's start with a new diagnosis. The medical team has completed its workup, and based on all diagnostic evidence, the provider is ready to deliver the new diagnosis. The patient or family, grounded in their faith, might be understanding that this diagnosis is a test of their faith, a trial of Allah, or punishment for their sins. Now the provider is prepared to discuss treatment options, focusing on an array of options and their respective benefits and risks. The patient and family might be hearing all these words and concluding that these are all instruments of God, all the treatment options, even the nurses and doctors and the entire staff, instruments that God will use as He executes His plan. The team may wish to clarify goals of care to align with the patient's plan of care as his stated goals. The faith-based person might be focused on concepts such as hope and reward, stemming from God's grace and mercy, and may not even be able to articulate or relate to the concept of personal goals. When it comes time to discuss prognosis, the provider might wish to communicate her best estimate of how long the patient is expected to live. But the faith-based patient and family may believe that the patient's longevity is in God's hands alone. As the illness progresses, the medical team might attempt to discuss likely outcomes with aggressive measures and life support. But the patient or family might be understanding these interventions as a demonstration of their faith or patience. Finally, it might be time to talk about withdrawal of life support. And the patient or family might understand this as asking them to participate in homicide, suicide, or demonstration of a lack of faith. There's nothing formulaic about this process. We do not expect providers to become theologians or miracle experts, but instead to maintain the connection and respond to the patient's invitation to journey with them through their experience. Next slide, please. Now, let's turn to some particularly triggering miracle conversations. What makes these conversations so difficult is that the family or patient uses faith-based evidence to express their rationale for a miracle. Clinicians may be triggered to address the basis of this evidence and miss the feelings and communication opportunities behind these arguments. So in the first case, Veronica, the daughter of a 78-year-old patient with stage 4 cancer, shares, "They told my mom she would only live 2 or 3 months, and she's still going after 4 years. And she's not the only one in my family. My cousin was told she would only live a year, and now she's graduating from college. We have seen miracles in my family. God is taking care of us." This is the story of a patient, family member, or friend who's had a miraculous recovery. What to do? Listen to the feelings behind the story, affirm similar feelings in the current case, briefly identify the differences between the cases, avoid but, and end with affirming hope and feelings. In this next case, Sam, whose son has been on a ventilator for longer than the medical team believes is beneficial, explains to the attending physician, "We must keep my son alive till God works His miracle. He will walk in His victory." This is the request for prolonging futile medical interventions while waiting for God to work His miracle. What to do? Explore the meaning and significance of a miracle. Provide a balanced, non-argumentative response. Negotiate patient-centered compromises while practicing good medicine. In this next case, a despairing wife shares, "We've been married for 47 years. I cannot imagine my life without him. God will not let this happen." This is the presentation of patient or family's desired outcome as synonymous with God's will. What to do? Affirm God's omnipotence and omniscience, explore the family and patient's desires, assess for other psychosocial needs, and communicate next steps. This last example, a loving husband speaking of his young wife who is an ICU nurse, emphatically states, "You don't understand. My wife is the kindest, most compassionate, giving person in the world. God knows she is worthy of his miracle." This is the argument of the merit of the patient or family as worthy of a miracle. What to do? Hear the patient or family's merits. Reflect on their accomplishments and traits and legacy. Affirm God's goodness, mercy, and grace. And with that, I'd like to turn it over to my colleague, Rhonda Cooper, who is a United Methodist minister from Johns Hopkins. Thank you.
Thank you, Leah, and thank you to everyone for joining us this afternoon. The work that I'm going to present was born out of real-life clinical challenges in our cancer center, given that most everyone who enters our door is full of hope for healing by medicine, by miracle, or oftentimes a combination of both. Also, I offer appreciation to my colleagues here in the Cancer Center, who are all my teachers, regardless of their discipline or their role. Now, first, as Leah noted, the belief in the possibility of a miracle in the healthcare context is not a minority opinion. The Pew Research Center reports that almost 8 out of 10 Americans, religious or non-religious, believe in the possibility of a miracle, with that figure shifting somewhat across the globe and across cultures. Closer to the healthcare home, however, there was an intriguing 2008 study in the Archives of Surgery in the trauma setting, in which one of the takeaways was that in the face of medical futility, 57% of the public, that's almost 6 out of 10 people, believed that a miracle healing was possible. That is, despite a grave prognosis. Even more surprising to me was that 20% of the healthcare workers, including medical providers, 1 out of 5 healthcare workers in the trauma setting also believed that God could reverse a hopeless outcome through a miracle. Now, you know this, but since the belief in miracles is at the heart of many religious traditions, the person hoping for a miracle may be firmly grounded in their faith. I would also say that the person who hopes for a miracle may have consciously or unconsciously realized the limits of human ability. In other words, the limits of the team to turn around a seemingly hopeless medical situation. Indeed, the person hoping for a miracle may also be acknowledging the limits of modern medicine, even though they may truly consider the medical provider a conduit or an instrument of God's grace or divine power. There's a really interesting study about this, 2002, in the southeastern part of our country, which is where I also hail from. All of this is to say that we do well to consider the belief in miracles as more normal than we are sometimes comfortable in the healthcare context, rather than seeing the belief or the hope as anomalous or atypical. And why would we not hope for a miracle at some points? How many of us have cried out for a miracle from the depths of our soul when we've learned of the serious illness of a loved one? I certainly have. How many of our patients have told us they, quote, hold out for a miracle as a coping strategy? That is, to keep their spirits up in the midst of discouraging news or a discouraging circumstance. And as we know, already said, in a number of faith traditions, the belief in the historicity and possibility of miracle is truly foundational. Now, I would suggest another motivation for miracle hope in the clinic as well. And that would be as an attempt to abate the power imbalance between provider, and provided for. That is inescapable in the healthcare context. In healthcare, staff wear the badges and the uniforms. The providers have the power to prescribe particular treatments or not. Staff exercise the authority to discharge as well as admit to service. Care recipients are keenly aware of this power dynamic. And of course, we know as chaplains that power relations are always relations of struggle. So I do wonder, is the belief in a miracle healing a way of holding on to some autonomy, some power, whether it be spiritual, emotional, or positional? So we have these challenges when engaging with a care recipient, whether a patient or their care partner, when encountering their hope for a miraculous healing. In addition to the power imbalance and the struggle it engenders, there are also these pre-existing trust issues, which go both ways, provider for patient, patient for provider. Indeed, chaplains know that attachment theory goes a long way in understanding why we sometimes react rather than interact with those in authority. Finally, we may miss the fact that denial may also be a way of coping, a way to, quote, get some rest in the face of so much information and bad news. Of course, I'm an optimist, so I would say that every challenge presents an opportunity, as well as an invitation to engage, and engage with respect and sensitivity. Now, I'll be honest, I am not a fan of the term, quote, false hope. I'm more inclined in the direction of Chaplain Steve Nolan, who explores the creative tension, the creative interplay between hope and denial. In his 2012 book, Spiritual Care at the End of Life, which many of you may have read, Chaplain Nolan takes the old psychoanalytic theory about, quote, hope development and suggests that every level of, quote, denial has a corresponding level of acceptance. Denial, acceptance, denial, acceptance, which then considers the process and the conversation as an organic living exercise. Hope, denial, and miracle go together. They all hold hands, skipping down the hallway and right into those family meetings to discuss the proverbial goals of care. Now, an example of a conversational protocol which illustrates the value of acknowledging and joining, which is, of course, foundational to emotional intelligence theory, is this one that you see called Value, developed by a team in Seattle. And I think it's a very clever use of the concepts. In terms of the miracle hope, our Hopkins team proposed the Amen conversational protocol as a way of remaining in relationship with a care recipient, even in the face of disagreement or misalignment about goals of care or treatment options. as with the value protocol, at the heart of the Amen is the commitment to hear, H-E-A-R, the care recipient, and join them in conversation. All of this while staying true to our role to educate and inform, with the provider's integrity intact. And again, based in research, the conversation always includes the assurance of non-abandonment of the care recipients by their team, for better or worse, no matter what. Amen. Affirm, meet, educate, no matter what. Amen. So here is some scripting. And again, the provider is encouraged to be true to him, her, or themselves when engaging. Some providers could, with no hesitation, offer, "There's not a day I come to work that I don't have a lot of hope and much prayer for my patients." Another could say, "I hear your hope. I always approach my care of your loved one with hope." Again, the provider is encouraged to stay true to who they are. Then, one of the keys, a very important key to the effectiveness of the protocol, is the use of the word "and" rather than "but," when shifting the conversation to the information that the provider is duty-bound to present. But negates what was just said and done, the validating, the joining, while "and" signifies two people in conversation, perhaps even resulting in a momentary suspension of the power differential. And of course, the reassurance that the team members, and that is plural by intent, the reassurance that the team members will be with them every step of the way is the most gracious way, if at all possible, to conclude the conversation. So the power of the Amen is not in the capacity to fix anyone or anything. The power is rather in the hearing and the being heard, as well as the joining, particularly when it comes to the, quote, hope for a miracle healing, despite all medical evidence to the contrary. Sometimes, to be honest, I wonder if all the care recipient is wanting to hear is that when it comes to life and death, that is life with a big L and death with a big D, when it comes to life and death, maybe they just want to hear that there is some mystery behind our well-meaning and well-informed prognostication. And finally, I do believe that hope can become the meeting place for all concerned, despite differences in expectations or perspectives. So again, thank you all so much for your interest. Here are a few references with the Amen article in yellow highlight. And now please give your attention to my colleague, Sarah.
Thank you so much, Rhonda. So I'm so happy to be here and in conversation with my wonderful colleagues. And the approach that I'm going to take is really to kind of back up and take almost a wider view to really think about how this impacts our relationships with the teams. And so Rhonda said that, these conversations are really an invitation, right? And I especially think these conversations are an invitation for us as the spiritual care specialist, really to claim and own our role within the broader healthcare team, whether we're within a palliative care team, and then also beyond to our floor teams, to our colleagues that we're working with day to day. And so I'd like to talk a little bit, you've probably heard the term team distress. Team distress is when the team, the medical team, our colleagues, social worker, really anyone we work with, can be a result of competing goals of the different service lines. It manifests in people expressing that they feel stuck, they might feel frustrated, they might feel confused. It can manifest in a palliative care consult, which is always good, and a consult to chaplaincy. But it's that kind of moment where they call you and they might not know why they need you, but what they know is that what they're doing is not quite working, or the conversations with the family and the patient and the different teams are kind of not really going anywhere and we're stuck. And so I think as chaplains, we know how to sometimes listen more deeply, to hold that space, use the language both of our own team, our medical providers, as well as the language of spiritual or religious or existential coping. And so we can navigate that by aligning ourselves with the team while also not being afraid to really engage a conversation with the families that we see. Also, just as a sort of framework to remember, there can be biases impacting the way that care is presented. Certainly, we know that there can be biases related to different religious frameworks or different spiritual frameworks coming from the providers themselves, needing to be aware of their own internal framework. Also, we know that health disparities, people of color, we know that, known or not, these things are something that can impact the amount of pain medication that people can receive. It can impact the way that people are spoken to, the way that people are related to, if we are feeling that the patient in front of us is very different or very similar to ourselves. So as the chaplain, again, we can bring this lens, and it's very important to understand that our lens is to back up a little bit, to see those dynamics within the team, and to really encourage our team when it's appropriate, our colleagues, whether this is in a group or kind of on the sidelines, to have that internal awareness and that sense of self when they are interacting with patients and families who are seeking miracles. I love this picture. This was one of my patients. I happen to be Orthodox Christian, and this was one of my Orthodox patients who, valiantly navigated his end of life illness, but he just stuck up his icons right on the glove box there. So I thought it was like a perfect example of navigating this. And my colleagues were sort of amazed by him because he was so faithful and so thankful at every moment. And it was really beautiful. Next slide, please. So team distress again. Now this is from a slide that actually the text was written by my MD colleague, so it comes straight from her. But this was related to a case we presented in the early days of COVID, where it was a young patient. The family used religious coping to navigate the awful complexities of that time. And they said they believe it's in God's hands, they're hoping for a miracle, and the team was really struggling. And she said these were the legitimate team reactions on the medical ICU. Anxiety, they had fear, they didn't know what to do. And when the mother said, I believe in God and I believe that God will heal my daughter, they just didn't know how to respond. They were skeptical. They wondered if this is really going to happen. They felt uncertain. They almost felt paralyzed. They didn't know what to do. So my colleague's response in the middle there is to breathe, to take a moment, to kind of assess the situation. We do that as chaplains too, but just to calm down for a second, right? And always take the stance of a curious explorer, using our fabulous phrases that we have in palliative care and also within chaplaincy. Tell me more. What does that look like for you? But again, not judgmental, but open and interested genuinely in learning. Hopefully you can partner with a chaplain to do a joint visit to round together. If you don't have a chaplain to work with, which, as we know, we don't always have enough chaplains to go around, obviously to advocate for more chaplaincy resources and support. And also I, fangirled a tiny bit when I met Rhonda, because I have taught the Amen protocol to many, many of my colleagues. I include it in every teaching I do with our fellows and with our medical residents. But again, I actually even wrote it up on little pieces of paper and printed them out and gave them to people in the ICUs. So it's just a handy tool for our non-chaplain colleagues to easily use and to not feel so nervous when patients use that language, but to really have a script that will help them. Next slide. Rhonda mentioned that there is, and also Leah mentioned there's this power imbalance. There can be this imbalance in the sense of needing to think about authority and control and really who's in charge here, right? So I like these images together. So that's the Sistine Chapel, Michelangelo, the creation of Adam, right? And then there's a doctor and patient holding hands, and then maybe a family member or friends at the bottom. But where does authority come from? Where does power come from? Who is a healer? Is it God, the Holy One? Is it the doctor using the doctor's medical tools and skills to heal a patient? Is it that connection with our loved ones? Is it some combination of all three? And so again, it's important to think about what are patients and families using as their source of understanding authority and power? Can we name that? Can we think through it with them? Sometimes people think that physicians are using, or God is able to utilize physicians, medicine, surgeries to facilitate healing. Some people think it's sort of totally separate. Other people rely fully on their perception of science or medicine. And so again, it's not a bad thing that these things exist, but it just is. And again, for us to be able to name that within the team and to notice that dynamic and that framework can be really important, just to kind of give a sense of what's really going on. Next slide, please. I love this picture of my team. It's the social worker, there's me, there's two of my physician colleagues, an NP fellow, MD fellow. It's, truthfully, I've been a chaplain for 20 years, half my time in hospice, half in acute care and palliative care. And I was not always included in family meetings, truly. So are you included in family meetings? Do you even know when they are? It can be really hard to even know. Everyone's super busy. You can't always figure out when it is from the chart or from the notes. But again, do your best, especially with those patients that you're actively involved with, to know if there's a family meeting happening and to not be afraid to join. Also, I kind of sound, a little bit cheesy, but I often say when I'm doing trainings, I'm like, if you hear the word miracle, call me. But truly, instead of, there's been some great research published around this, one with Ernickoff, where they looked at like 250 ICU family meetings. There's only like 2 chaplains, and 2 of the meetings were chaplains present. But oftentimes the surrogates or the family members brought up spiritual or religious coping. And so there was no one there to receive that language and to hold it and to deepen it and nuance it. And that deepening and nuancing of the spiritual or religious language is really what we have to offer. And when we can do that in a family meeting in front of our colleagues, using our skills, I really think it changes their perception of what spiritual care can be. And going forward, they might think, okay, when they're having to stress about treatment decisions, especially if they're using this spiritual or religious language, they know that we will call them not only to care for the patient and family, but to help the team talk more openly and more authentically with the patient and family using their language. Next slide. So with my colleague, Dr. Leah Rosenberg, I recently wrote a fast fact, which is like these handy online palliative care tips. And I wrote one about communication with patients and families that use spiritual care language or spiritual language and hope for a miracle. It's easily found online. And I just wanted to share one little bit of it. Oftentimes I hear teams say things to us that kind of, on the sidelines, they sidle up to me and they say like, wow, this patient and family, they're still hoping for a miracle. Maybe they just don't get it. But the thing is, right, they worry that they're lacking insight into the seriousness of their illness. But actually hoping for a miracle can be a coping mechanism that implies a certain level of insight, right? They actually do understand how serious this is. They do understand that we are reaching the end of our treatment options and therefore are hoping for a miracle. It's actually totally appropriate. And so again, as long as we know that they have received appropriate and thoughtful communication, we don't have to say, oh, they just don't get it, but instead understand that they do get it and are utilizing their coping skills to hope that there is going to be more time or there will be more healing. And again, there's this framework that we see in the palliative care literature, hoping for the best, preparing for the worst. We talk through the best case and the worst case, but we're kind of in this in-between place, the best, the most likely scenario. And that's where we promise that no matter what, we will be with the family and patient, no matter what happens. Next slide. I see we're kind of reaching our time and we want to have time for discussion, but just to lift up, again, that there are major ethical principles that arise in these kinds of situations. And it's so important not to ignore or kind of set aside the spiritual or religious coping, because the families and patients, the language that they're using and the choices that they want to make, or the things that they're offered by the team, they evoke these ethical concepts such as beneficence. For example, what will truly help the patient and their family members? Will this fourth line of chemo really help them? Will this extra surgery truly help them? Maybe, maybe not. Is it appropriate? Is it medically appropriate? Are we causing suffering for the patient? Is there a way that we can prevent further suffering while still honoring their spiritual or religious practices and their hopes? Is the situation perpetuating inequity? Are there choices that we're making that are really actually questionable in terms of justice? And also autonomy, this is huge, right? Are we respecting the patient's wishes? Are we respecting the healthcare proxy's ability to discern and make decisions? Are they fully informed? And is their spiritual, religious, cultural background being respected and really being engaged in good faith by the team? And by the team, I mean chaplain and the medical team. And finally, my last slide. I think it's important for us, many of us also work in the grief space and in bereavement. And I think it's so important to think about how our engagement with these concepts can impact grief and bereavement. For example, what happens if the family prays only for a full bodily healing and it doesn't happen and the patient still dies? How does this impact their grief? Could someone lose their faith, lose their sense of the holy? And of course, there's no answer to these questions, but it's important for us to have that, to think through it. And what I've found oftentimes is even if a patient and family are hoping for a true miracle, a full healing, or that something miraculous will happen, as long as they are given the opportunity to share and speak through and pray through their faith and utilize that coping that is so natural to them, even if their loved one still dies, oftentimes they are able to know deeply within themselves that they did everything they could. And that even if they wanted to pursue more aggressive treatment, and the team recommended, let's make your loved one a DNR, DNI, let's protect them from aggressive treatments that won't help them. Even if they don't pursue the most aggressive thing, they can still hope for a peaceful end of life. They can hope that their loved one knows that God is with them. They can hope that God is with them and they feel that. And I can think of many times when I've had to say to a loved one at a dying person's bedside, I know you were really hoping for a miracle and I see your loved one is dying. Like, I wonder what that's like for you. And this patient I had, her brother said, we trust God. We did our best and we allowed space for God to work, for the holy to be present in this room. And we know that God is with us. So yes, they were holding those things together, that hope for a miracle, while also respecting and hearing the appropriate treatment recommendations from the team. And so when we can use this language honestly, not to be afraid of their language about miracles and hoping and all these things, but instead to say, tell me more, to be a curious explorer, then we're really providing the best care that we can for our patients and families. And my last slide is just some references. Thank you. I will hand it over to Dr. Eric.
Thanks, everybody. If the rest of the panelists can join, I learned so much from all of you today. So I really want to thank you for joining on this webinar. I really want to come back to something that, it took me a while. We don't get a lot of training in medicine about spirituality and how to address spirituality. in our clinical practice. And it took me for well over a decade to figure out that one thing you mentioned, Sarah, is that when somebody mentions they're hoping for a miracle, I used to get so scared and like anxious and thinking like, oh, they're in denial, they don't understand what's going on. And then it finally dawned on me, oh wait, it actually means we're in prognostic agreement here. Like everybody understands the severity of what's going on, and it would take whatever you define a miracle as, intervention from a supernatural being or an incredibly rare event to happen. We are all in agreement, and that has helped settle me as a clinician from jumping to what I hear the most is, oh, they're in denial. And I wonder, Sarah, when you hear, let's say, the team go, oh, they're in denial, they don't understand kind of the severity of what's going on here. Do you have like how do you react to that?
Well, first, I remind people that denial is sometimes a very appropriate coping mechanism. If we hear everything that's hitting us, that's happening to us, we might not be able to put one foot in front of the other. So a little bit of denial comes and goes, right? It takes a minute to process sometimes the stuff that's going on. So first of all, again, we all exist in various states of denial and presence and acceptance. So it's not like an awful thing, right? Yeah. Also, I would want to clarify just truly to make sure that the family or patient has received the appropriate information directly and appropriately. Right. There's sometimes maybe they actually really don't know what's going on because sometimes they haven't had good communication in the team. So I double check to make sure that they've had a few efforts at really good communication, honest communication. And then I would just try to support my team member to say, I know, it's so hard. It's like, look at the person. And then you think, how can they think that they're going to get better? But just again, to kind of normalize the experience of like, we're in this together. We're not sure what to do. You can't hit the family and the patient over the head with what's going on. It's totally not appropriate. And the thing is, even with, the patient, we say, oh, the patient's in denial. They think they're going to go home and this and that. The patient is in their own body. They are experiencing what's going on in some level. We do our best to communicate, but we can't force things. And what we can do is provide a safe environment, a supportive environment for them to be heard, to feel supported, and again, that key phrase of like, no matter what, we're going to be with you. And if it hits you and suddenly you're not in denial and you realize the gravity of the situation, we will stand next to you and stay with you when you cry.
Thank you. So I'm going to go through some of the questions that we're getting online. The first one is from Robert Tabak. And a couple of questions around this theme of when we're thinking about and I often see this when we talk about prognosis, there's things that people are hoping for and things that they expect. So for example, like I occasionally play the lottery. I hope to win the lottery. You can try to dissuade me from that hope and tell me it's a false hope. I know Leah brought that up. But it doesn't matter because I don't expect to win the lottery. And when we're thinking about miracles and hopes, how do we think about kind of what patients are hoping for as far as a miracle and what they're expecting? And how do you tease that out from patients or family members? I'm going to turn to Leah.
It's a great question, and I think it's helpful to start with the Latin, right? So the word miracle comes from miraculum, and if you think about it in that larger context, it simply means a miraculum is an extraordinary event, marvel, or wonderful thing. And who can't get on board with joining somebody who is expecting a wonderful thing and who hasn't experienced that themselves? I like to start with joining.
And then how would you define what hope means?
For me, hope is a resource that not only is necessary for patients and families, but also for clinicians. It's something we draw from. It's something that You know, again, I'll use my own tradition. You know, in Israel, the national anthem is Hatikva. It means the hope. And we couldn't live without hope. We can't function without hope. But hope is not a determinant of outcomes. It's an essential for living.
Okay, Rhonda, I got a question for you. When we're thinking about hoping for a miracle, I think, you know, I see a lot of physicians, including myself, who maybe naively potentially think that, oh, we just need to reframe their hopes. Have them focus on other things, hope for other things. Can we just hope that the miracle will be that we're able to discharge him home and he spends a couple last days at home in hospice? What do you think about reframing hope?
I think it's up to the care recipient to reframe that hope. I don't think any of us can do that work for them. I think they see through it, number one. If the patient says, oh, I'm hoping I'll be healed, and one of us is, any kind of provider says, oh, I think really the best the best hope or the best miracle is that you get home and, you know, your cat gets in bed with you. I think they would see through that, you know, unless they say it. I mean, I've had patients say to me, what I really want, what I'm really hoping for is I want to go home and I want all the cats in bed with me, or I want to sit on the porch and have a beer, or whatever they want to do. But that's up to them to determine. Not, they can reframe, but we can't reframe for them. Does that make sense?
Yeah.
I think if we sometimes say to a person open-ended, so what are you hoping for? We may be surprised at what they're hoping for. It may not be what we thought they were hoping for, but we can't, you know, that's part of their respecting their autonomy to also reframe. I mean, I think it's a nice idea to think we could do that for them, but I don't think they really want us to.
If you try to reframe my hope for winning the lottery, I think you'd be sorely disappointed.
Right.
I got a question for you, Sarah. Can you speak to when the family is praying and truly hoping for a miracle, but the patient is not, or is accepting their prognosis? Again, accepting prognosis is weird because in some ways hoping for a miracle is accepting prognosis. How do you deal with that?
Ooh, that's an interesting one. I've definitely had that. Like, I had a patient who had an Impella, you know, in the cardiac ICU, and the family was like, believe in God and take your, like, not be on or have the Impella. I don't even know what the language is, but an Impella is like the most aggressive cardiac treatment you can be on. And so, you know, and like, stop using it and go home. And they were like, don't you believe in God's word? Don't you believe in God's word that you can be healed? And the poor patient is just there with like 87 lines and just trying to navigate, you know, his existence. And, you know, it's hard. I mean, I think the family does it as a way of trying to bring hope and support the patient. Most of the time, I think 99% of the time, it's done out of a loving place. It's done out of a place of like, this is what we believe and we're going to encourage you. And the patient may be experiencing inside themselves, you know, this kind of coming to terms with the fact that their prognosis is poor and their life is kind of reaching its end. So, I mean, sometimes, I mean, obviously I'm not going to shut it down or do anything like that. I certainly encourage people to pray the way they want, the way that they'd like to. I would also offer, you know, invite the patient to offer their own prayers or to share with me what they're hoping and praying for, and I will use that language in prayer too. You know, I think the universe is big enough to hear all types of prayers. And so I might, if I can find the patient alone a little bit later, I might allow them some space to process it privately with me if they feel like their family's kind of pushing them or trying to make them feel a certain way. I might give them some space just to reflect on that. I might also try to do the same with the family. But again, their journey, I'm just meeting them for this small snapshot of their life, their faith, their life, the miracles they've had before. Maybe their family has experienced 40 miracles in the past, or what they see as miracles. And so it's very consistent to hope again for another miracle. So I can explore that with them. I can nuance it. I can hear them. But again, I'm also not, I don't need to be intimidated by it. I don't need to be thrown off by it. But instead really just to hear them and to make sure, again, that we're communicating what's ethically appropriate, what's medically appropriate, and hearing them in that. And I think sometimes all these things kind of air themselves out. The key is to allow the space for it to happen and not try to shut it down, because otherwise it might come out in kind of unhealthy ways or inappropriate decisions.
And aren't we all?
I want to be mindful of the time. I realize that we are now 2 minutes over. Leah, Sarah, and Rhonda, very big thank you for joining this absolutely wonderful webinar. Paul, where can folks see the recording of this webinar?
Yeah, thanks so much, Eric and Leah and Sarah and Rhonda. I really big kind of arms around kind of embrace. Yeah, thanks so much. Please check out Transforming Chaplaincy's YouTube page. Just type in Transforming Chaplaincy. You will find that. It is free. Love to have you check out our website. We'd love to have you again. You go get the QR code from there if you want to join the network. We'd love to have you be a part of us. Of course, please check out the Jerry Powell podcast if you want to just give a little plug there as well. But again, thanks to all of you for the work that you do at the bedside in research and how you contribute to the healing for the people that we get to encounter that are going through some really hard times. And tomorrow, we just got on base with this webinar. If you want to knock us home, please tune in. Dr. Tracy Balboni, George Fichette, and others will be leading a webinar on spirituality in serious illness and health on a paper that was just published in JAMA. So don't miss out on that as well. Thanks so much, everybody. Thank you for joining us. Be well.
Thank you so much.
Thank you, everybody.
Thanks, everybody.
Thank you all.
Great job.
Thanks,
Great job, Chris. Thanks so much. Bye-bye.